during the lunch, during the So interperitoneal pivacin has been studied quite a bit recently, and a number of the studies have studied it. We investigated it in laparoscopic cholecystectomy, and it has been found to be to help a lot with pain and postoperatively, and also reduce the frequency with which patients request for rescue analgesia. So all these studies are really recent studies. So like I'd mentioned, a lot of the principles that deal with ambulatory surgery are the same even in minimal access surgery, on top of the things that are nitty-gritties for minimal access, nitty-gritties, for minimal access. So in the discharge criteria for minimal access surgery, usually we use the PAD system, which is used more for a discharge home, unlike the Aldrich score system, which is used more for discharge to the ward. And it addresses things like vital signs, ambulation, surgical bleeding, patient unit, then ability to drink when applicable, the location of the home, presence of caretaker, all those are checked again before the patient is sent home. Phone contacts are checked. Then the mode of transport when returning home. I know for Kampala patients, everyone will come in a car, but in Chabira, some of our patients come on borders. And sometimes we don't want to do a laparoscopic cholecystectomy, and then send the patient home on a border. So we must ascertain what's your mode of transport home. If you don't have a car, can we get a special hire? And they're usually special hires at affordable prices. Or if none of those is affordable and the patient is it seems like they can't afford anything, we may use our ambulance at a subsidized cost to get the patient home. And then medication and feed instructions and contacts of the field nurse. And then for the home follow-up, the patients, we have the contact of the person for home follow-up is available 24/7, and then the patient will be called on postoperative days 1 to 3, and then they usually visit the hospital between days 5 and 7 for follow-up for review. But the patient should expect to be visited by a health worker at their home. That way you'll be able to successfully carry out an ambulatory surgery for minimum access. So that is Chabira Surgical Center, and we're always open to partnering with people, and very grateful for this opportunity to share with all of you, some people. Thank you very much.
Well, thank you very much, Arthur, for the elaborate presentation, and thank you very much for sharing with us your experiences at Chabira. It is really amazing how many patients you have seen and the kind of work you're doing. Thank you. I don't know whether we have any questions in the chat box before I invite other panelists to share their discussion. Does anyone have any question in the chat box? Or if you do have any question, feel free to raise your hand, unmute yourself and ask. I'll open the platform for about 10 minutes for questions to Dr. Arthur.
Dr. Arthur, it's Dr. Daniel Heron joining from New York City in the United States.
Yes, Dr. Heron, you are welcome to this panel, and we are glad to hear from you. Good morning.
Thank you very much. It's a pleasure. It's a pleasure to be joining you. I guess you are 7 hours ahead of me. It's just about lunchtime here.
Yeah, that's
I thought that your talk was very interesting. One thing which we have done commonly for postoperative analgesia is TAP blocks or transabdominal plane blocks, where we'll use bupivacaine and inject that along the abdominal wall between the muscle layers in order to get long-lasting analgesia. And I'm wondering if that's something which you've tried or considered at the Chabirwa Center.
Thank you, Dr. Heron. It is something that we've not yet tried, but we are planning to try on our next cases. Based on the mechanism of action and the site where we deposit the drug, I'm sure it would be very good for the abdominal wall pain. Currently, the abdominal wall, we use infiltration of the ports and try to make the infiltration a bit deep to all the levels. So far, it seems to have been working well, but I would want to try this out, partially on obese patients for whom infiltrating the levels may not be as adequate as in the lean patients usually get. I think it would be very, very helpful, because TAP blocks have been shown to be effective in controlling abdominal wall pain, even up to 18 hours after it has been put. So it's something worth really trying out. And the benefit of laparoscopy is that you can do it under direct vision, where you see the peritoneum swelling up as you infiltrate. I imagine that is the technique that you use, because the other techniques available are landmark and ultrasound guided. For the benefit of laparoscopy, you're able to see the peritoneum swelling up as you inject around the as you inject around the port. So that should be you can try out.
okay. Thank you very much for that, Dr. Harold. Now that you're here, would you kindly want to share with us your experience in New York? I know you run an ambulatory center there. I'm personally a gynecologist, and I know we have a number of gynes in the audience, and pretty much of our surgeries are actually short surgeries, especially diagnostic laparoscopies, hysteroscopies, and the rest. And I'm quite sure most of our patients would be able to benefit from this kind of arrangement. Would you be kind enough to share with us what you do in New York?
So we have we do many operations on an ambulatory basis. Some of them we do strictly in our ambulatory center, which is exclusively ambulatory, but we also do many ambulatory operations as part of our main operating room in the main hospital. Typically, the operations that we're doing on an ambulatory basis from a general surgery standpoint would be things like inguinal hernias, small abdominal wall hernias, gallbladder surgery, gastric surgery, and then of course gynecologic procedures, plastic surgical procedures, etc. One of the issues that we have a big problem with is the postoperative urinary retention, and I wonder, is that something which you also encounter much in your setting?
We haven't encountered postoperative urinary retention.
Interesting. That's probably our single most common complication for inguinal hernia repair. And we do a lot of inguinal hernias. Excuse me. So we do find that we have an incidence of sometimes 10% or even more of urinary retention, which can slow down our discharge. So that's one of the issues which we face on a fairly frequent basis here in New York.
Yeah, but considering we don't do that many laparoscopic inguinal hernia repairs, maybe that is why we don't have that number. But then also in addressing, I think someone is talking about in the chat, someone has talked about complications. The commonest complication we've had, like I mentioned, we've had 36 patients so far. Of those, maybe about 3 to 5, the issue has been those who need rescue analgesia. And then another smaller percentage has been those who maybe get nausea from that if we add on a weak opioid on top of their pain management at home. So they may experience nausea here and there. Then usually when we stop the opioid, they are okay, pain-free and without any nausea. Yeah.
Okay, Dr. Damoy, are you there? I know you do quite a number of surgeries. I had an opportunity to listen to one of your presentations on another platform, and I was amazed at how many of these things like cholecystectomies and such you've done and allowed your patients to go home. Can you share with us your experience, given what we've been talking about?
Yeah, thank you so much, Dr. Spire, and thank you all listeners. Yeah, the practice of ambulatory surgery at Chabira Surgical Center, I would confidently say has been a success. Personally, I came from a background where I was on the conservative side. I don't like to send home my patients too early. But we've done a wide range of procedures and been able to send patients home same day. And I must mention that our patients are from the typical rural Ugandan setting, those who do not have good means of transport, those who you may think communication, understanding communication, sometimes it's not so easy. Patients in a typical rural setting with all the challenges you may imagine, but we have had a good outcome. I would look at how many times have we had to readmit a patient who has been discharged, sent home, and they got a complication and bring them back to the hospital. The answer is actually 0. I think twice patients whom we could not understand their issues from home, we asked them to come back to the center, but they didn't have any serious complication, probably pain, something really. And range of procedures, all the inguinal honey, good number, they have gone back home. We have done a number of appendectomies of quite significant sizes. I think the biggest we have done is about 600 grams, more than, so, and we're confident on the same day, they have covered very well. We've done a number of surgeries, including mastectomy, that have gone home same day, covered without an issue. Like Dr. Arthur has mentioned, we have done a number of laparoscopic procedures, intra-abdominal cases, and we have gone home safely without any medication. So I would confidently say daycare surgery is very feasible, even in a rural setting like ours. I mentioned laparoscopic surgery as day's talk is. Laparoscopic surgery is quite the best surgery daycare practice. There is less pain, experience less pain, and there is minimal disturbance of the patient's physiology, and the recovery is generally faster. So it is even make daycare practice much better. But of course, like I already mentioned, even with many open procedures that are done, the daycare practice has been very successful. I would mention daycare surgery must be a team practice. You can't just decide as a surgeon that I'm doing daycare surgery when the rest of the members on the team are not. Nurses should be educated. They should know how to communicate with the patients. remember your patient may be in recovery room, will be with the nursing members of your team. So they should have the same knowledge. They should be able to answer the patient's concerns the same way. In other words, all the team should be prepared. Not that this is any special preparation, just the members knowing that the patient is going to be handled on a daycare basis so that the communication is uniform. When a patient comes, the first person who gets contact with the patient thinks of, does this patient have an attendant? What means of transport is this patient going to use for going back home? How far does this patient live from the facility? Are there any special considerations we should put in place? Things that if the surgeon did not remember because at the time they are so focused on the surgery, then the rest of the members on the team would have thought through about them. So it must be a team practice. And Dr. Arthur already mentioned about pain control is key. Most of the time surgery, patients think of pain. So once you've controlled your pain adequately, it will all work well. And we use oral analgesics mainly. The moment the patient is out of the hospital, they are going on oral analgesics, also oral antibiotics. So it is not any special pain control medications again. It's a combination analgesia, probably paracetamol, maybe tramadol if a patient can tolerate, diclofenac, any of the common analgesics we use really, just that we use a combination to ensure that patient's pain is adequately controlled. So I would say team practice, patient selection, and then communication. Communication is where every team of the members should be able to communicate with the patient at the same wavelength. That's all I can add.
Thank you very much for that. That's really takes some work. It looks like the team has to be integral in this kind of business. Arthur, if I can come back to you, I just kind of curious how you go about your anesthesia, knowing that the patient has to go home. I'm sure a lot of anesthesiologists, anesthetists in this crowd need to know, how do you manage your anesthesia? Because sometimes I've realized that patients take a long time to wake up. Is there anything special about the choice of your anesthesia for these patients?
Thank you, Dr. Kiggundu. So there's a number of factors really. The principles of enhanced recovery after surgery, if we just pay attention to many of them, a lot of the things that keep patients in hospital are the principles of enhanced recovery after surgery address those things. So making sure that the patient doesn't come in hungry, then doesn't stay hungry too much after they are woken up. But then also the kind of drugs we use intraoperatively, we try to utilize more of shorter acting drugs where you know that the patient is not going to have that drowsy effect so much after the surgery is done. So for example, may not really use maybe let's say ketamine as my main anesthetic because by the time that is completely out of the system, patient may take a while before being ready to go home. So preference for using propofol, and then if you're sure of surgeries that are short, usually most people would use fentanyl as their opioid. You know that fentanyl within 1 hour is really getting out of the system, so you can top up with other analgesics that have a different mode of action. Then in the fluid status, avoiding overhydrating your patients, but also not underhydrating them. So that's where a patient should come when they have not really starved, when they have not starved for long, but then you hydrate them appropriately. Then postoperatively, also you don't overhydrate them. The earlier they return to oral hydration, the better. Then it's really a number of things like that, and working together with a team. The teamwork aspect is very key in achieving this.
All right, thank you very much. I have a few questions in the chat box. If you could kindly answer some of these. I can see Eddie asked, thanks for the presentation. How do you minimize the risk of LAST? I don't know what LAST is, with intraperitoneal bupivacaine.
Yes, so LAST is local anesthetic systemic toxicity. So there are studies that have been done and they have measured the plasma concentration of bupivacaine after instilling intraperitoneal bupivacaine. And some of those studies, they used up to about, they used a range of 100 milligrams to 150 milligrams of bupivacaine. And they found the plasma concentrations were way below the toxic the levels. So and then also these other multiple researches that have done quite a number of patients and have not reported local anesthetic. Have not reported any symptoms or signs of local anesthetic systemic toxicity. So both the plasma has been measured, but then also clinically, the patients who have undergone, who have been involved in these studies have also turned out to be okay.
Right, I think to follow up with that question, again, Dr. Simatimba wants to know the mechanism of action of intraperitoneal bupivacaine.
So one of the things that causes a lot of pain postoperatively for minimaxis is the shoulder pain from the diaphragmatic irritation. So the bupivacaine, usually, because you give it in a large volume, low concentration, it numbs the pain receptors around the diaphragmatic areas, such that it reduces the referral of that pain that gives the shoulder pain. And then maybe the general abdominal peritoneal irritation that comes from the surgery. There are cases, for example, for lap chole's where they only irrigate the gallbladder bed and then the right hemidiaphragm. But then there have also been some studies where they irrigate the entire peritoneal cavity with bupivacaine. The only one I've done is the one of irrigating the gallbladder bed and the right hemidiaphragm. I've not tried out irrigating the entire abdominal peritoneal cavity. But all those, the local anesthetic one through the pain referred via diaphragmatic irritation, it helps a lot with that. But then also from whichever peritoneal irritation that may come from the surgery, it can also numb that pain. So when you add that combined with the abdominal wall blocks that you give at the end, your patient should really be very stable.
Okay, thank you for that. I think this one goes to Dr. Damnoy. I know you've answered one of them. In your experience with your method, what is the incidence of complications when patients are home? What are the commonest complications? You can also follow it up with what operations offer a high incidence of complications. And also someone wants to know that whether it is possible to do laparotomic surgeries under this kind of setting.
Thank you. So complications, our overall complications rate has been less than 7%, I think 6 point something. That is the overall complications rate for a cohort of about close to 2,000 patients, maybe 1,800. Those are the ones we analyzed. So the overall complications rate was less than 7%. it's a range between 7 to 15%. So our complications rate has been quite within acceptable. And out of this, none of them was really a major or a lethal complication. And I already mentioned we didn't have any readmissions really. Majority were seromas in hernia surgeries, probably because it's the more common surgery done also. But in the major surgeries we do, I mentioned the thyroid surgeries, the breast surgeries, a number of the major surgeries have not come back with the feared major complications. So overall, I would say it has been very safe and very comparable to admission settings, if not slightly better. Laparotomies. So Dr. Arthur mentioned about patient selection. You will definitely pick on cases that fit in an ambulatory surgery center, predefined cases that don't fit in an ambulatory surgery center, cases that definitely need admission. If I got a patient with intestinal obstruction, we are likely not to take on that patient because that patient requires admission out of fluid support over many days. So there are cases that do not fit in daycare surgery. The only important thing is to know that the range of cases that still fit in daycare surgeries is not as small as we would imagine. It's not only the minor cases that fit in day surgery, as I already mentioned, and the rest of the cases we do. Thank you.
I think Dr. Sudais also wants to know, I think this goes to Arthur. How do you calculate your fluid requirements for these patients? Because I understand you emphasized quite a lot about being careful with the amount of fluid you give your patient in order to avoid perhaps bloating and all that. Can you throw a bit more light on this?
So I don't use a specific calculation because every patient varies, and then you gauge on the patient's response. Generally speaking, I tend to be fluid restrictive compared to a lot of my colleagues. So I find that if a patient comes in when they are already well hydrated and then their vitals are normal, and then when they start insufflation of the CO2 and you get the normal peritoneum, many times if a patient is hypovolemic, that insufflation will find the patient's blood pressure dropping. So usually I say that it unmasks hypovolemia. So in that, if I get a situation like that, I would give more fluid. But most times what I would find, if my patient comes in already well hydrated and the procedure doesn't last beyond an hour, at most I won't give them even more than a liter of fluid. But then you can't give a rule on this because it's not a black and white thing. It's you tailor it to each patient. So if you find your patient, despite coming in seeming like they are well hydrated, and they still show symptoms of being hypovolemic or behind on fluid, you would still need to give them fluid. I find it easier for a patient who is normal and not bleeding. I find it easier to come from negative fluid state than try to correct a hypervolemia where now I've given too much fluid and I want to correct that. So generally speaking, in my own personal practice, I'm not saying this as a rule for people. I find it easier to chase normovolemia from behind than to try and reduce the fluid inside the patient to come back to normovolemia, which found it to work better for my patients.
Okay, thank you very much, Arthur. Dr. Professor Heron, are you still with us? All
Yes,
right, yeah.
I'm still here. Yes.
Yes. I'm kind of curious to know what kind of laparoscopic surgeries, if you can list maybe a list of 10 for us. What kind of laparoscopic surgeries are you able to do as daycare surgery in your setting?
So the most common ones that we do as outpatient operations would be cholecystectomy, hernia repair, and the types of hernias are most frequently the inguinal hernias. We'll also do umbilical hernias and ventral or incisional hernias, also using the laparoscopic approach. Occasionally, we're using the robotic approach for these operations as well, similarly through 3 small incisions on the side of the abdomen. Those are the most common general surgical procedures. We also will do a fundoplication laparoscopically, and that's also can be done as an outpatient procedure. Looking at then going to the gynecologic procedures, oophorectomy, diagnostic procedures, diagnostic laparoscopy would be up there with the most common. Of course, laparoscopic tubal ligation would be common as well. But I think then laparoscopic appendectomy on a more urgent basis would be the next most common general surgical procedure. So it's a broad mix. I'm in the United States, we have kind of more strict differentiation between the general surgeons and the gynecologic surgeons. So I'm not doing any of the gynecologic procedures myself. Excuse me. But what we found is that with the laparoscopic approach, obviously there's less abdominal wall pain from the incisions, but there are certain things that we need to look out for from an ambulatory perspective. The carbon dioxide gas that we use to insufflate the abdomen does cause irritation of the diaphragm, which is perceived by the patients as shoulder pain. And so many of them are surprised when they get home to notice that they've got shoulder pain from the insufflation irritation from the carbon dioxide gas. And they're a little confused because they have not had any procedure on their shoulder, just a procedure on their abdomen. So I think it is important to educate the patients beforehand to know what to expect. And I think just simply telling them that it's very normal to have shoulder pain and that will go away by tomorrow helps our patients to be a little bit more relaxed about that. But in the United States, we're doing, almost all of our appendectomies are now laparoscopic. All of our gallbladder surgery is laparoscopic. It's about 50%, 50-50 with regards to inguinal hernia repair. So there are many people doing them routinely laparoscopically, but there are also many of them, many surgeons are still doing them through open surgery. Obviously, regardless of whether it's open or laparoscopic, it can still be done in an ambulatory setting.
That's exciting. Still with you, I just want you to give us a take-home message because I think the reason why most centers wouldn't want to embrace ambulatory surgeries is mainly out of fear of the unknown. What take-home message do you give to most of the people in the audience who would want to start doing ambulatory surgery? I know obviously the benefits are enormous, and if we have to start talking about the benefits of minimal access, one of them is for sure the patient being able to go home quickly, less pain, less blood loss. But I'm looking around at the logistics the hospital has to use when you keep a patient for more than 24 hours really. So in our kind of setting, a low economy society where we know that most of the people are breadwinners, you wouldn't want to keep them in hospital for long. I'm quite sure this is the kind of approach that would benefit the common man out there in the village. So what take-home message do you give? I know you know Chavira very well. You've been where you work there. what kind of type of message would give us for us who want to initiate this kind of practice?
Well, for me, it's been very inspiring to watch Dr. Joseph and Dr. Arthur get Chabira up and running at the wonderful, very high level of quality that they've been able to achieve. And I think that as they've been discussing, that the rates of complications for most of these operations are very low. The things that we see most commonly are, things which are not very severe. We see things like postoperative nausea and vomiting, which is typically going to resolve on its own. But in terms of major complications that keep surgeons up late at night worrying, things like bleeding or major infection or things like that, these are complications which we haven't really been seeing. And so I think that it's incredibly important to do everything possible to make the surgery of as high quality, just the way, the surgery has to be high quality and the anesthesia has to be high quality, and the patients have to be educated about what to expect. And as Dr. Arthur was discussing, you have to have a mechanism of communication, typically a cell phone, but most everyone has access to a cell phone at this point. So in the rare situation where something does arise, where it's not going to be able to be managed and they do have to return to an emergency room or back to the ambulatory center, as long as the patient has the ability to call back in through a cell phone, I think all those can be managed to an acceptable level of risk. So if your question is how can we avoid being scared of moving to an ambulatory setting, I think the thing to look at is the patients. I think that's what the patients want. Like you said, they're breadwinners. They have to get back to their house, to their family, to their work, to taking care of things. I think the less time they spend in the hospital, the happier they are, so long as they feel like if there's a problem, they know how to get in touch with the center. So I think we should dive into this opportunity responsibly. But I think it's ultimately what our patients are most interested in, and I think it's safe to do.
Thank you very much, Doc. Someone in the audience wants to know which sort of medication analgesia you give your patients going home. Is anything different from what Arthur has discussed?
My favorite medication is ibuprofen. Ibuprofen is very widely available. It's very cheap. It's very safe. I know some doctors are concerned that it could, in theory, interfere with platelet function and increase bleeding. But overall, I found that there's, if I tell patients that they're going to be able to manage maybe not all of their postoperative pain, but maybe 60 or 70% of their postoperative pain by taking ibuprofen, and they can take, they can take 600 milligrams or 800 milligrams if they need to. Most of them are able to do so. And I find that very few need any type of narcotic pain medication. So I think ibuprofen is just a wonderful medication. I think particularly if you're giving bupivacaine either intraperitoneally, as Dr. Arthur was talking about, we very frequently will do bupivacaine through this tap block, which when we're doing laparoscopic surgery, we actually can see inside, and we insert the needle until it's just about to enter the peritoneum, and then we pull back a few millimeters so we're in that proper plane where the nerves are passing. But by giving good local anesthesia and by educating patients about they're not going to take care of all their pain, but they can take care of most of their pain with non-narcotic analgesics, I think that ibuprofen is a wonderful medication. So that's my personal favorite medication.
Thank you. Yeah, it is indeed cheap and widely available. Do we have any questions from the audience? Please feel free to unmute yourself and ask the panelists. Do we have anyone in the audience with a question or comment? Yes, Dr. Were, I can see your hand up. Kindly unmute yourself and give your question or comment. Dr. Francis?
Yes, thank you very much. I hope you can hear me.
Yes, yes, yes. Go right ahead.
Yeah, thank you very much for your nice presentation on ambulatory medicine. Mine is just a comment about our setup here in Kenya. For the longest time, or maybe I first of all mention that I'm actually a gynecologist. For the longest time, we've been having ambulatory surgery in very, very few centers in the country, and particularly in Nairobi. But since the year 2002, there's been an upsurge of ambulatory surgery, and particularly among those who have been performing laparoscopic hysterectomies, cystectomies, and even occasionally myomectomies, have actually been enjoying ambulatory services. And this is coupled by having very, very well-trained anesthetists who currently are able even to perform the tap blocks and give proper analgesia to these patients before they go home. And what I've seen, the practice is most of these surgeries are done early in the morning, in the better part of the morning hours, so that there's enough time to observe these patients until late in the evening. So usually they are discharged around 5 p.m. or 6 p.m. and occasionally accompanied not just by relatives, but by a nurse to just watch over them for overnight and make sure that they are stable. And in case of any challenges that they notice, then the anesthetist is just a phone call away, and even the surgeon can actually be called in, and the patient may be probably brought back to hospital for proper attention. Thank you.
Thank you, Dr. Were, for giving us the Kenyan experience. Certainly, on the gynecological point of view, I know ambulatory surgery has a bigger role to play in a number of our patients, because I think most of our cases are quite short and possible. To you, Dr. Harold or Dr. Damoy, someone wants to know which kind of pediatric procedures have you been able to do? Is it possible to perform pediatric surgery as ambulatory surgery? Any of you can take on the question.
I'm not very qualified to answer because, again, I don't do any pediatric surgery at all. But I would certainly think that certainly pediatric hernias could be done very well as ambulatory procedures. Dr. Joseph, are you doing any pediatric procedures at Chabira?
Yes, that's right. We do a number of pediatric hernia cases, and all of them done on ambulatory basis. They all go home. I think a few days ago, we had a child with strangulated inguinal hernia, and because the gut was still viable, patient actually was managed on ambulatory basis. So majority we have done has been inguinal hernias, and yes, all of them have gone same day. And actually, I think it appears like the pain tolerance of this group is much better. We have had much less concerns of pain with this group. So majority have been in hernias.
Thank you. Lastly, I just want to have the last word from each of you, if you don't have any more questions in the panel as we plan to close. Anyone, your take-home message? I know Arthur, someone is asking if you can give them a few of your protocols. Maybe they can inbox you for that. Give us your take-home messages, please. I'll begin with Arthur. Do you think ambulatory surgery is possible to be extrapolated from Chavira Surgical Center to other centers? What should we do?
First, I want to thank you for this opportunity, and then also ambulatory surgery is possible. The things that make ambulatory surgery possible are not that complicated. A lot of them are organizational things of making sure the patient is well prepared before the procedure, making sure that they are accompanied home and they are followed up at home. There is a lot that forms the basis for a lot of the ambulatory surgery. And most of the surgeries we do, most of the surgery is done in Uganda and even in the world, and probably fall under ambulatory surgeries, even up to 70%. Yeah, so it's something that is very doable. The thing I see in most hospitals, the only thing they need to add to be able to do ambulatory surgery is get a person who calls the patients before and plans for their coming, and then get a person who follows the patients up at home and have that person trained on what to look out for and when, and to know when the patient should come back to hospital. And then ambulatory surgery will be very possible. For the protocols, we are happy to share and just connect outside this forum.
Thank you very much, Arthur. Dr. Joseph, your take, last message.
Thank you again. My take-home message: ambulatory surgery is very safe, and I think it has many advantages for the patient, eventually to the health system. Definitely, I would encourage my colleagues out there to initiate it, to start practicing ambulatory surgery. In my own experience, there are patients I would discharge without a blink, really, and I know they will be very safe. You should start small. I guess right now, probably you still have questions. You haven't maybe experienced much of it firsthand. So you should start small. Start with your first patient, see how they will do. Your protocol doesn't have to be like ours at Chabira Surgical Center. We are a specialized ambulatory surgery center. But you know, if you cannot follow your patient at home, they can come back to your facility on day 3 or day 4. You can call them on day 1, find out how they are. Then you can schedule them to come back for you to see them on day 3 or 4. And eventually you begin to realize that these visits don't have much need actually, and you can start scaling down on you know, visits back. But I think you should start. Many advantages to the patient, many advantages eventually to the health system. We know sometimes we have very long waiting lines in facilities because space or other logistical issues. Ambulatory surgery could help more patients access the needed surgical care. So I would think start, and like Dr. Arthur mentioned, reach out to us outside this forum. We'll be happy to offer further guidance, share more experience. Thank you.
Yes, we shall certainly reach out to you to help us kickstart this journey into ambulatory surgery. Professor Harold, it was such a pleasure to have you here. I know in the wee hours of the morning in New York, but you took time off to come and share with us. We can't take that for granted. Kindly, your last take on this.
Well, I would just echo everything that we've already heard. I think that it's a great thing for patients because patients don't have to spend time in a scary environment like the hospital. For pediatric patients, it's a wonderful thing that they can be more with their family and less time in the hospital. And I think as long as you're careful about choosing your procedures wisely, making sure that your patients are adequately screened, selected, you have a means of communication with them by cell phone, that there's a caretaker available, by just being very careful and judicious in the manner in which you're choosing both your patients and your procedures. I think that that ambulatory surgery can make more operations available to the population in a safe and cost-effective way.
All right. I want to thank very much our panelists, Dr. Arthur, Dr. Damoy, and Dr. Harold, for taking time out to share with us what you do in your respective centers. Certainly, we have learned a lot. I'm sure the audience has learned a lot. And we are ready to embrace ambulatory surgery as one of the ways to enhance the advantages of minimal access. I want to thank the audience for sticking with us all throughout. I do want to apologize for the hitches and glitches which came in between the presentations. But for everyone, thank you very much for attending, and we shall meet again next time. Thank you and bye.
Thank you.